Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
So about neurosurgery as a specialty in general. So a way to kind of think about it is that we're kind of tasked with the diagnosis and treatment of disorders of the nervous system. That includes the brain, the spine, peripheral nerves, and the vessels that supply them. A lot of times, it's true of me too. I thought of neurosurgery and I thought brain surgery, but it's so much more than just brain surgery. There's spine surgery is extensive and super interesting in and of itself, as well as peripheral nerve surgery. And knowledge of and appreciation of all of those is essential in neurosurgery. Things that I'd want to point out about the field itself, it's very integrated. And what I mean by that is it doesn't rest on just a knowledge of how to do the procedures, how to do the surgeries. The patients who you treat as a neurosurgeon can be very sick. And a knowledge and an understanding of ICU medicine, critical care medicine, is essential in understanding, what's happening to your patient and how best to manage them. We really we emphasize, not just the knowledge of surgery and anatomy and all that, but really ownership of the medical side of things as well. And then along with that, along with the sort of the surgical and operative understanding is in understanding neuroradiology. We spend a lot of our days scrolling through CAT scan, head CTs, MRIs, and that kind of thing, and both understanding what's happening to the patient, but also trying to understand if there is something that we can do surgically to help them. And all this happens across the lifespan in neurosurgery. So there is the field of pediatric neurosurgery, which we all, as residents, all get exposure to, and you can choose to specialize in it, all the way to 90, 100-year-old patients who have a fall and have some sort of trauma, and they need to see a neurosurgeon and have that managed. It's a young discipline. A lot of the advances that kind of founded the field happened around the turn of the century, around the 1900s, and as a result of that, there's the field has advanced very rapidly in that time, and there's very much this focus on on trying to make the field better, trying to push it forward, and that's both in the sense of surgical technology, but also how can we understand the pathophysiology of the diseases that we're treating, and as a direct result of that, as I was mentioning before, there's definitely this focus, especially in academic neurosurgery, on research that advances the field. And lastly, it's a small field. There's only about 3,500 practicing neurosurgeons in the country, about 100 residency programs. So those numbers are a lot smaller than some of the bigger residencies. And as a result, as mentioned before, that there's a lot of people in the field really know each other, and it's very tightly regulated, such that you go to a residency program and you're going to get well trained. You're going to, like anything else, you're going to get what you put out of it, but they're regulated such that you're going to see the surgeries that you need to see and get the experience that you need to get, because there's generally just so few programs. The subspecialties within neurosurgery, it's already seems like a very subspecialized field, but there's there are many subspecialties within it. The main ones here, so tumor being brain tumors are kind of you can specialize specifically in the surgical treatment of brain tumors. Cerebrovascular disease, that's a field that needs its own fellowship, and basically combines endovascular treatment with open surgical treatment of vascular diseases, things like aneurysms, arteriovenous malformations, cavernomas, things like that. Skull base neurosurgery deals with pathology, obviously around the skull base, which is a very complex region anatomically, some of the best anatomy in the human body, no bias here, but something else that you can further specialize in and deal specifically with surgeries that are dealing with that region. Pediatrics, as I mentioned before, that's another subspecialty that you need a fellowship for. Spine within itself has a couple of different pathways. There's minimally invasive, which kind of leverages a lot of new technology that's coming out recently, which has kind of redefined the approach to the spine. And deformity, which is correction of really things like really bad scoliosis, kyphosis, things like that, which can really improve the quality of life of people who are suffering. Functional neurosurgery is another just rapidly expanding field that's changing, really, it seems, by the day. And what this entails is probably some of the videos that you've seen of deep brain stimulation, when people have a stimulator put in the OR and their tremor goes away such that they can play a violin, or do things that they just never could before. This field also deals with epilepsy, the treatment of refractory epilepsy, and along with movement disorders like Parkinson's disease, there's this rapid expansion to attempt to treat refractory psychiatric disease with surgical intervention as well. So definitely a lot of really exciting things happening in functional neurosurgery. And then peripheral nerve surgery is the treatment of things like tumors of like the peroneal nerve or carpal tunnel syndrome, nerve transfers. Patients who come in with after really bad trauma may have a brachial plexus avulsion, and they can get their brachial plexus, certain nerves grafted to in an attempt to restore function. So basically, the point here is that there's a really sort of broad practice within neurosurgery, and in residency you get exposure to all of this, and you get really a better sense of what it is that you're truly interested. Especially in cities with like multiple medical institutions and things like that. In those settings, there's definitely a trend towards going to a specialist to see them for a specific problem. But I'd say there's despite the trend towards subspecialization, which I think is true of all of medicine, the capability is there to deal with the basics of all of these after your residency. So the residency itself is now, it used to be that some were 6 years and some were 7 years. It's now standardized into a 7-year training program. And the breakdown of that is basically as follows. So an intern year that is mostly focused on neurosurgery. You may have some additional rotations in general surgery. This is something, it used to be the case that you would spend an entire intern year in general surgery and then move on to neurosurgery. However, it's the case now that you spend most of your time in neurosurgery, but you spend some additional rotations doing things that that'll ultimately be helpful for you in laying a foundation. Your junior residency is consists of a lot of in-house or home call as you get more senior in your years, and that really is the foundation of really understanding how to manage patients both before and after they get it into or out of the operating room. Patient comes in with a neurosurgical problem. The goal of in your junior residency is to be the person who can stabilize that patient, who knows what are the next steps that need to happen to take care of this patient, oftentimes save their lives. And then after they get out of the operating room, what are the common postoperative problems that patient can run into, and what are the solutions? There's also a focus on developing kind of the fundamentals of operating. So things like things you may not even think about, things like positioning the patient, opening, which can be opening an incision and getting down to a specific anatomical structure that you'll be working on, which can be very different in different surgeries. Closing an incision, some of the more basics of surgery there. And that's, you see more and more cases, and just like, a lot of, other surgical training programs, and really just medical training programs, there's the sense of graduated responsibility as you get further along in your years. Most neurosurgical programs have research time that's built into the residency. Now, this goes back to, again, this emphasis on advancing the field and understanding more about what it is that we're doing. That's where that research time comes from. This may be in different programs. It may be organized differently. It may happen at a different year. It may be split up into certain different parts of your residency. And different programs have differing amount of call responsibilities that you may have during that research time. But the idea is that you have some time dedicated to research. And then lastly, as a senior resident, you're more from a management standpoint outside of the OR. You have sort of the big picture responsibility of overseeing the service, making sure that the right things are being done for patients, that they're moving along, that any big problems are addressed. And in the OR, there's more, of course, a focus on operative nuances. So what is the best next step, or what is the what are more the details and the specifics of the surgery that I'm doing. And after your residency, I talked about a couple of those subspecialties. Some of them absolutely require fellowships, and for others, if you feel like you want to get some more exposure, you can choose to do a fellowship. So that's generally how it's broken down. A day in the life in residency, it's tough because it really differs based on where you are in your residency. I'd say, as a junior resident, there's definitely a lot of time that's spent in the hospital. Just sheerly for the goal of seeing enough pathology, enough disease to really understand how it behaves and how it changes over time. One of the striking things about neurosurgical pathology and just nervous system problems in general is that things can change very quickly. For example, a patient who has a subtle change in mental status over the course of, let's say, 24 hours. Each hour, the delta in that mental status is rather small, right? So to the point that you may not, if you've seen that patient from, time point 1 to time point 3, you may not notice, much of a change, but from time point 1 to time point 24, you can refer back and say, okay, there's something major that's changed here, and something, might need to be done surgically. That's some of the justification for spending that much time in the hospital is. And and I think it's true of all neurosurgical programs that those junior resident years, are definitely a grind. But it's about as I generally say, it's about the journey rather than the specific destination. And then as you go on to your senior resident years, less time in the hospital. However, you're still, you have a essentially like a foot in the door where you're in communication with your junior resident who's there about what's going on in the hospital, and you may go in to see emergent or to do emergent cases. As an attending, obviously I'm not an attending, but I can kind of speak to as far as what I've seen with the attendings that I've worked with. This is kind of a typical breakdown of a week. So a couple of clinic days. So this is an example. This could be a surgeon who deals specifically with spine problems. Right. So a couple of days of clinic a week where there's patients who are referred to you. These clinic days are spent, really, seeing a lot of patients, depending on how busy you are, but also before seeing them, reviewing their scans, reviewing, their story, what the actual referral is for, and then going and seeing them, talking to them, and kind of understanding, trying to put together, does, this MRI that they came in with correspond to, what exact symptoms there are, and is there a surgery that I can offer here? That's a fundamental question that happens in clinic. And then you have, maybe 2, maybe 3 OR days for the week. So these are scheduled elective cases. So the patients that you saw in clinic, let's say a few weeks ago, were added to the OR schedule, and you're going in and you're doing those cases. I'll talk about what that OR day looks like on the next slide. And then, in this breakdown here can vary, very wildly. You may have specific research time built in, have a research day based on how your schedule is constructed, or you may be, laying that out at different points along the week. You may have administrative work. You may do another, a part day of clinic there, and then, as with other specialties, you're generally splitting up call with your colleagues. So on a weekend, you may be on call for this entire week, which entails fielding phone calls about consults that may need neurosurgical intervention, and that may extend into the weekend, or you may have that to yourself. So that's a typical week, I'd say. As far as what an OR day looks like, 7:30 is kind of a typical OR start time, but you'd typically get into the hospital well before that to round on your patients, and to really to kind of catch up on what's happened over the course of the last day, and then see your patients before their surgeries, and then get going on the surgery. The number of cases, the length of these cases is another thing that varies wildly. If you're doing a quick laminectomy for degenerative disease, it'll be a lot. Your schedule will be a lot different than if you're doing a big complex skull-based tumor, and you plan accordingly. The end of the OR day can also vary depending on how many cases you have that day, how those cases are going, whether or not you have any add-ons if you've been on call. But typically, I'd say somewhere in this 4 to 7 p.m. range. Might be earlier if you only have a couple cases. It might be later if you've added on cases or there's emergencies that have come in. As I talked about, additional between cases, you're seeing patients who are in the hospital already. You're working on your research and admin tasks, that sort of thing. The big thing that I've taken away is that there's no such thing as a benign surgery. There's no surgery that you can take for granted, because just the nature of the beast, that things can go wrong, either in the OR or afterwards with complications, and you always have to be ready to address them. Okay. So I'll go through some cases here. And, I chose these cases to, basically kind of illustrate some of the integrated nature of the field of neurosurgery. There were, it was tough to narrow it down to a couple of cases, because there's so much to talk about, but hopefully this will be helpful. So the first one is a 49-year-old female. She's got a history of hypertension and cigarette smoking, presents with the worst headache of her life. You go down to see her and she's nearly comatose. She was described to you as drowsy but maybe saying her name, but by the time you see her, she's a lot worse than that. For someone to be nearly comatose and getting worse, certainly there's systemic things that could be going on, but especially with this initial description of worst headache of life, you're starting to localize to something involving the brain. So she gets a CAT scan, and this is what you see. Does this look normal to you guys? Oh no, right? So there's a lot of what would on CAT scan what we'd call hyperdensity, all this bright stuff here. That's what blood looks like on a CAT scan. This is an axial slice of a head CT, just to kind of orient you a little bit. And basically, the way this works is that the patient's laying on their back, and you're sort of standing at their feet and looking up, and they're kind of sliced this way as they go through the scanner. So this is the front of the head, this is the back of the head, and the sides are switched such that this is the left side and this is the right side here. So we see, basically a lot of this bright blood that's sitting in what's called the ventricles of the brain here. And there's some blood here that's sitting inside actually the parenchyma of the brain, which is the actual substance of the brain. So I just wanted to show you a normal head CT for comparison here. And basically, you can see a few things. So obviously all that blood shouldn't be there. That isn't there normally. The ventricles themselves, these are very interesting. So these you can see are normally they're not too prominent. They're there. You can definitely tell they're there. In this case, they're kind of ballooned a little bit. You can see that this is definitely a lot bigger than what this is. The other thing to note is, and this is a bit more of a subtle point, but here, this out here is gray matter in the brain, and this is white matter. And there's usually what's called this nice gray-white differentiation, so you can tell what's gray matter and what's white matter. Here, you can kind of tell here, but you're starting to lose that. And that's a sign that there's a lot of pressure that's built up inside the head. The brain is being kind of squeezed up against the cranial vault because of all this blood that's in here. And along with all this blood, there's additional swelling and things like that are happening. So this is a differential for blood in the brain. A differential is basically a list of things that you start thinking about when a person comes in with a specific problem. So this is someone who came in with a really bad headache and now has a lot of blood on their CAT scan. Things you think about are trauma. This is the most the most common cause of blood in the brain is someone falls and has a little bit. This is way more than you'd see with trauma, and in a totally different location than you'd see. Ruptured aneurysm is another one, and this is something that you've certainly heard about. And that it has some poor clinical associations and things with it. Other things are arteriovenous malformation, cavernous malformation, Hypertension is related to bleeds in the brain as well. They have very typical locations, basal ganglia, specific parts of the brainstem, cerebellum. This doesn't quite fit that here, but it's important to keep that in mind. And a hemorrhagic tumor is something else that you can see. Again, location-wise, this doesn't quite fit that because we're seeing primarily blood in the ventricle. It certainly could happen, but it's less likely in this case. So we deal a lot for these very sick patients with saving their lives to start off with, right? We know in this lady's case, we know that there's a lot of blood in the brain, that there's some kind of vascular problem happening. But the primary goal right now is that this is a comatose lady that we're dealing with who's getting worse, and we need to make sure that she's okay, and that her vital organs are supported before we do anything further. So we talk a lot about the ABCs: airway, breathing, circulation, and even though we're dealing with blood in the brain, the most immediate concern is her airway secure? In her case, it's not, and she's getting a lot worse. So you can imagine if we let this comatose patient, kind of continue to do what she's doing without without intubating her, the whole goal of treating her neurosurgical problem will be a moot point because she'll die from that instead. So getting her intubated and making sure that all of that is stable first is how you always start with these patients. You also want to consider their cardiovascular status. So some patients may come in with with a primary neurological problem, but they may as a result of that have a really bad stress cardiomyopathy, which may have may have depressed their ejection fraction of their heart, and now they can barely hold a blood pressure, and that needs to be addressed as well before you're addressing their neurological problem. And those are general principles of medicine, and they apply here in neurosurgery absolutely as well. And this is something that you can do at bedside. Here's really quick, just a cartoon of the ventricular system in the brain. So the ventricles hold cerebrospinal fluid, which sort of circulates around the entirety of the ventricular system, out through the subarachnoid space of the brain, down the spinal cord, and back up. It's responsible for several different things, including cushioning, nutrition of the brain, et cetera. But once that space is enlarged, which it is in this case, you've now effectively increased the intracranial pressure significantly. And a major point to consider here is that we talk about the brain as existing within a closed cavity, within a closed vault. The skull can expand. It's fixed in its size. So as you're building up, there's swelling inside the brain, there's blood inside the brain. There are a few things that can happen. CSF, that cerebrospinal fluid, it can move out of the brain into the spinal cord. The brain itself can move, as we saw it, pushed up against the skull. But there's not much. There's once you hit a certain inflection point, the brain starts getting ischemic, the brain starts getting damaged, and if you don't act quick enough, the same patient who you intubated to save from dying from respiratory failure can now die because of brain death or brain injury causing brain death. So how do you address this? And like I said, this is something you can do at bedside with something called an external ventricular drain. So what you do here is you make what's called a burr hole, which is a small hole in the skull after making an incision, and using landmarks, which are just kind of shown here. We won't get into specifics, but it's a certain amount, behind the bridge of the nose, a certain amount related to the mid-pupillary line here, and you aim a catheter in a certain direction, which you learn how to do. But you aim a catheter in a certain direction, you get into the ventricles, and it shoots out CSF, and that same inflection point that you're at, where that patient could have very quickly have fallen off and had severe brain injury, you've brought them back because you've drained off CSF, and now there's an exit. There's some sort of exit for some of that pressure to go. So that's what happens initially. That saves the patient's life, and then brings into consideration further neurosurgical intervention. So once we've done that, once we've made sure that she's doing okay and she's alive, now we already have a strong suspicion that that this is some kind of brain bleed, and based on the pattern of bleeding, there's a strong suspicion that this is an aneurysm rupture. You get what's called a CTA, which is CT angiogram, essentially, where you inject contrast into the vessels and they show the vessels of the brain. And here what we can see is this is an axial slice here. This is basically the end of the carotid artery as it comes up into the brain. At the end of the carotid, it branches off into the anterior cerebral artery, the ACA, and the middle cerebral artery, the MCA. And you can see here, actually on both sides, which is unusual, but was the case for this lady. She has two very nasty looking aneurysms. And an aneurysm is an outpouching blood vessel wall, usually at the junction of two different vessels. Here, it's the end of the internal carotid artery as it splits off into the anterior cerebral and middle cerebral. Here, this was, if you remember, there was blood that was basically inside the parenchyma of the brain that I was talking about. That corresponds to the rupture of this aneurysm into that part of the brain. These blood vessels exist in the subarachnoid space. That's where they are anatomically, which is in communication with all the CSF in the brain. So when these aneurysms rupture, they have there's a risk that that blood will go into the ventricle, which is what we saw here. So that's where all that blood came from. And the hydrocephalus, the actual mechanism for how that happened was that this blood is now sitting in the ventricles, and it's essentially preventing the drainage of cerebrospinal fluid where it would normally go. Which is, nicely would kind of fall through here, go down here, and then go down here. Now you have all this blood that's in here. It's both blocking the resorption of cerebrospinal fluid, which happens, basically at the ependymal lining of the ventricle, but it's also blocking that CSF from flowing normally. That's why it starts, getting bigger and causing this increase in intracranial pressure, and that's why that catheter, relieves all that pressure and saves this patient's life. So now we know what we're dealing with. We've stabilized her. We know what the culprit is. Now the question is, what can we do to treat this? And the treatment of an aneurysm, this is something you may have heard referred to as the clip versus coil debate, or clipping versus coiling. And basically what that discusses, or what that gets at, is an endovascular treatment versus open surgical treatment. Open surgical is what it sounds like. It is making incision on the scalp, taking off a piece of bone, and going down to the aneurysm and getting control of it. Endovascular treatment involves going in through an artery and getting up into the cerebral circulation with by way of catheters and microwires, and treating the aneurysm from the inside. So rather than opening up the skull and getting down to the blood vessel and dealing with from the outside, you're coming in from the inside. That's the basic breakdown. There's different reasons that you do both of those. A lot of those dependent on morphology of the aneurysm. There's definitely in kind of the recent practice of aneurysm management, definitely a shift towards doing a lot of this endovascularly. And this is an interesting point. This is something you can train to do as a neurosurgeon, but you can also train to do this as a neurologist or a radiologist as well, by doing an endovascular, neurointerventional radiology fellowship. It's very interesting. It's kind of the confluence of three different specialties, approaching the same thing, but they come at it with different perspectives entirely. But that's something to keep in mind. If you have an interest in in the brain or cerebrovascular or brain problems in general, and the rest of neurosurgery isn't super appealing, there's still this route via endovascular treatment that you can deal with these problems. And like I said, this is a rapidly expanding field in and of itself. So like I said, different indications for each. This is just a cartoon of an endovascular coiling. So here, you've basically come up inside the blood vessel all the way up to the aneurysm, and you deploy basically, in this case, these are sort of platinum coils that basically occlude the aneurysm from circulation. So you can imagine, blood's coming in this way. If you ignore this for a second here, blood's coming in this way, and this aneurysm basically represents the path of least resistance, and it ruptures under conditions of high blood pressure as more and more blood comes in here, and then it, basically explodes through this wall of the aneurysm. So once you've put the coil in, what you've done effectively is, you consider the path of blood, it's going to come in here, and there's really no reason for it to go here. There's such high resistance because of the placement of all these coils. So blood will continue on its normal route. And what happens is that over time, this aneurysm itself will thrombose over, and it'll shrink essentially and not be a problem anymore. So that's how you can get control. So that's what this lady had done for the culprit aneurysm. Because of, again, specifics about its morphology, it was amenable to endovascular intervention, and she was able to get that treated. This aneurysm did not bleed. It didn't rupture at the time. So it didn't need necessarily acute intervention. And so, the focus was now shifted towards making sure she improved and got better. We'll talk a little bit about the post-op course and what that involves, but she eventually, I'd say even just a few months out from this, was actually on a cruise and doing great, which is incredible. This is the highest grade aneurysm rupture you can have, which carries a really significantly high mortality rate with it. So the fact that she was able to be doing that just a few months out from her hospitalization was really remarkable. However, that left this aneurysm, still at play, right? So she's already had a rupture, which predicts a risk for another rupture here. So how do we treat this? So this actually morphologically did not lend itself to endovascular intervention. So she actually ended up getting open surgery for this side, which I'll talk about a little bit here. So open surgery in general involves, basically there's a collection of different surgical approaches to different parts of the brain. The approach that you'd use to get down to where this aneurysm is specifically is called a pterional craniotomy, named after the pterion, which is the confluence of three bones right here on this side of the head. So the pterional craniotomy involves an incision that is basically shown here by the dotted line. These structures are things that you have to think about when you're making that incision. So the superficial temporal artery, that's the pulse that you can feel in your temple. The frontalis branch of the facial nerve, you don't want to injure that. That can cause issues with muscle function, basically right up here. And the frontal sinus is basically a structure that you don't want to violate because it can lead to infections if you get in there. These are considerations for incision planning. The other thing about cranial surgery is that head position is really important. This device here is called a Mayfield, which in some ways is a little medieval in how it works. So basically, you push pins into the head to hold it in place in a certain area. But what's interesting about cranial surgery is you have to, and I'll talk about this a little bit more, but you have to have a solid understanding of anatomy, of course, of 3D anatomy, and then you need to be able to turn it left, right, up, down, backwards, forwards as you move the head around to get to a specific region. So we talked about this being a carotid bifurcation aneurysm, which is basically the end of the internal carotid as it splits off into the middle cerebral and the anterior cerebral. So when you learn about carotid anatomy in med school, you learn about the branches of the carotid. You learn, you kind of see it as the structure that maybe has these specific branches, and then it eventually gets to the circle of Willis and the head. And then there's other branches that you have to memorize, and that's basically how it gets taught. But in neurosurgery, there's basically a necessity of understanding it in 3 dimensions and how it's related to the skull base, which I'm showing here. It basically comes through this portion of the temporal bone and rises up through here and takes these loops and turns and twists and all this sort of stuff. And you have to know what the relationship of it is with those bony structures as you're coming down doing your craniotomy. You also have to know where it's sitting relative to the brain in 3 dimensions. This is a cadaver specimen of a brain by a legendary neurosurgeon, the late Dr. Al Roten, who has these books of incredible dissections that teach you so much about anatomy. But one thing he says is that you have to have a 3-dimensional, 3D understanding that leads to an X-ray vision, where you can kind of look at this part of the brain, but know what's happening underneath. And as you go through in this area, you split the sylvian fissure, which is separation between the frontal and the temporal lobes. You work your way eventually down to the ICA terminus here, which gives off the middle cerebral branch and the A1 branch. But what you have to know is, what's not only the relationship of the internal carotid to those parts of the brain and the bone, but what's its relation to the cranial nerves that are around it. This is the optic chiasm. This is the optic nerve as it's coming back from the eye. And you have to know, what is that doing in reference to the carotid as you're doing your surgeries. And then what additional branches, there are perforating branches that are at risk here. So if you're not careful, you can injure those and cause injuries to other parts of the brain. Most procedurally, and this is kind of what I was alluding to before. For ruptured aneurysms that you're treating. Now, you can treat unruptured aneurysms. That's an entire different conversation. But patients who are at risk of having their aneurysm rupture, you can get ahead of it and treat it before it ruptures, which it behooves you to do, because in the case of a rupture, you're looking at least a 2-week, for the most part, at least a 2-week stay in the ICU. Typically doing things like watching for vasospasm, which is this reactive process whereby other blood vessels in the brain can actually vasoconstrict in the presence of all this blood that's around the brain. And once your blood vessels constrict, you have less blood flow going to the brain, and you're at risk for ischemia, you're at risk for strokes. And that's in those 2 weeks, there's such a high risk of vasospasm happening that you watch them like a hawk for those 2 weeks in the ICU. You monitor it. Hydrocephalus is the term for that increased intracranial pressure as a result of the ventricles getting bigger and that cerebrospinal fluid hanging out in the brain. You monitor how that's doing. Ideally, once you've treated the aneurysm, you don't have any re-bleeding or anything like that. You have a catheter in there that's taking care of things. Ideally, you can get to a point where you can get that catheter out. But sometimes these patients, their CSF flow is so disrupted that they actually need a permanent drain that's actually tunneled underneath the skin and empties into the abdomen. So that's the decision you can make kind of towards the end of that ICU stay. And as with any long-term ICU patients, there's other things that come up, things like pneumonias. If it can get bad, they can run into generally bad infections. They may have cardiovascular compromise as well. So those are things that you're watching very closely in a day-to-day fashion. And like I said, this is an integrated discipline, so it really requires this coordinated care. At most, at most like tertiary academic centers that are dealing with things like this, there is a neurocritical care team, a neuro ICU team that's kind of working with you in the management of these patients. And it's also possible within neurosurgery to, because you see so much of these critically ill patients, to also board certify as a neurointensivist as well, because of how much exposure you get to all of this.